Today we're going to discuss ROP stages 4 and 5. Stage 4 ROP is characterized by the development of scar tissue that causes enough traction to create a subtotal tractional retinal detachment. This stage is further subdivided into stage 4A, which is a subtotal retinal detachment not involving the macula. And this is the last opportunity to save good vision in a child before the macula is detached, which causes permanent reduction of vision. And stage 4B is characterized by a subtotal retinal detachment involving the macula. Management of stages 4A and B depends on its extent and the presence of active disease. An extramacular detachment away from the macula without an active disease can be observed, or you can consider a scleral buckle. Extramacular detachment threatening or involving the macula can be treated by lens-sparing vitrectomy. Stage 4B, with recent macular detachment, you can do a pars plana vitrectomy, while stage 4B with an established macular fold or macular dragging and no disease activity should be observed, as surgical intervention will not add any benefit to this eye. Lens-sparing vitrectomy is preferred in these neonates for several reasons. First of all, the lens-sparing vitrectomy, leaving the child in a phakic condition, allows for early and better visual rehabilitation after surgery, while removal of the lens in lensectomy vitrectomy procedures leaves an aphakic eye which is prone to amblyopia and limits visual development. It is worth mentioning that putting a scleral buckle results in a myopic shift and can affect ocular development, and therefore it should be removed after the original surgery 6 months later. Anatomical and functional outcomes of vitrectomy in stage 4 ROP are more favorable than stage 5, achieving a success rate of reattachment in 82 to 90% after a follow-up of 1 year. Vitrectomy in neonates differs completely from adults in several aspects. First of all, due to anterior insertion of the retina, the entry site should be at the pars plicata or limbus rather than the pars plana. The lens is relatively large, and therefore you should introduce your instruments parallel to the visual axis and not towards the center of the vitreous, otherwise you're going to injure the lens. Posterior vitreous detachment cannot be achieved easily or not at all. Breaks are extremely poorly tolerated, and the occurrence of any break means surgical failure on table. So this is a case of stage 4 ROP, and this is a lens-sparing vitrectomy. You can see the presence of this central macular fold and vitreous traction, and the aim of this surgery is simply just to remove the vitreous overlying the macula and to release the traction and the vitreous fibrils connecting the central macula to the periphery to prevent further traction and detachment. Using the scissor, we cut cautiously the fibrous tissue to release traction, and it is not your aim to leave the retina completely attached at the end of surgery. You don't do any retinotomies or drain any subretinal fluid. Endolaser is added to the peripheral retina, and finally a fluid-air exchange is done, and the sclerotomies should be sutured in these neonates to avoid post-operative hypotony. There is no place for sutureless vitrectomy. Stage 5 ROP is characterized by total retinal detachment, and it is usually a funnel-shaped retinal detachment with traction in all 4 quadrants. It is further subdivided into stage 5A, referring to an open funnel, and stage 5B, referring to a closed funnel retinal detachment. Management of stage 5 ROP, despite all efforts, carries a very poor visual prognosis, and you can promise only in best circumstances ambulatory vision to this child. We usually do a lensectomy and vitrectomy, and the retina may deposit with folds and poor visual acuity. All efforts should be directed towards early screening to prevent progression of these neonates to this unfortunate stage. This is a case of stage 5 ROP, and you can see the retinal vessels directly behind the lens and the presence of a total retinal detachment. The entry sites are done through the limbus, putting the infusion cannula, and the lens is removed. doing the lensectomy with the vitreous cutter, and then we remove the anterior vitreous very cautiously, and the retina starts to fall back once you release the anterior traction. We go inside very cautiously with the vitreous cutter and remove the fibrous tissue that is pulling the retina anteriorly. And it is worth mentioning that it is impossible to remove all fibrous tissue in these children, and attempts at vigorous dissection in these eyes can end up by iatrogenic retinal breaks and surgical failure. We just remove the necessary traction, which needs extreme caution and wisdom to know which traction components to tackle and which ones to leave. Again, after removing the fibrous tissue, the retina remains detached at the end of surgery, and it takes several weeks until the retina reattaches again, usually with folds in these cases. Thank you very much.